Before the chairman enters the chamber, I'll just read out the emergency evacuation announcement. Should we be required to evacuate the building, would you please leave the building via the nearest available exit to the chamber? Our assembly point will be in the public car park at the side of the Civic Suite. Please do not delay your evacuation to collect any belongings. Please do not return to the building until given permission to do so by council staff. Please note that this meeting is being audio recorded. May I also remind everyone to switch off their mobile phones or put them on silent. Thank you. Would you now please be upstanding to receive the chairman, the chairman's chaplain and the managing director.
Good evening, everybody. I'm going to have prayers from my chaplain, Mr. Richard Isles.
Evening, everyone. Brief story. Jack and Max were walking away from church, and Jack wonders whether it would be all right to dance while praying. And Max replies, "I don't know, why don't you go and ask the vicar?" So Jack goes and asks the vicar and says, "Father, would it be all right to dance while I pray?" But the vicar replies, no, my son, you may not. It is disrespectful." To his friend Max and says, he said no. And Max says, "I'm not surprised. You asked the wrong question. Let me try." So Max goes and says to the vicar, "Father, may I pray while I dance?" To which the priest eagerly replies and says, "By all means, by all means." And the moral is,
You may sit. I would like to welcome the members of the public who are here. It's very, very nice to see so many at one of our meetings. I would just like to just confirm with you that this is a council meeting, and unfortunately you aren't allowed to ask any questions, but I'm sure there will be lots of things that you will find interesting and find useful in this presentation. So thank you very much for coming. So item number 1, apologies for absence. No, haven't got it. Is there apologies for absence? Right, okay. Councillor Burton, Councillor Dray, Councillor Mrs Mason, Councillor Mr Mason, Councillor Ayanu and Councillor Mrs Rowe.
Chair, I was just going to say, with the apologies for Councillor Rowe, ironically, she's had to attend the walk-in centre at Southend Hospital.
Well, we send her our best wishes. Councillor Eaves.
Thank you, Chairman. Councillor Toby Mountain has sent his apologies, but he hopes to get here. He is running late.
Thank you. Councillor Black. Stanley, thank you. Councillor Hyde. Right, okay, thank you very much. Any other apologies? No. Right, item number 3. Oh, sorry, number 2. Can't count. No, can't read. To receive declarations of interest. Councillor Cutmore.
Thank you, Chairman. I'm a member of the Essex Health and Wellbeing Board representing the southern districts of the county. I chair the local Health and Wellbeing Board for Castle Point and Rochford, and I'm also a governor at Southend Hospital on behalf of Essex County Council.
Thank you. Councillor Webb.
Thank you, Madam Chairman. I also sit on the Board of Governors at Southend University Hospitals Trust, and my wife works as a doctor in Broomfield Hospital.
Thank you. Any others? No. Okay, thank you very much. Right, item number 3 is the presentation. It's the future of health and care services in the Rochford district, and we have representatives from the health service to do a presentation, and thank you very much for coming along tonight. And I think Dr. Ronan Fenton, sorry, over there, Dr. Ronan Fenton is going to lead the presentation, yes?
Thank you, Chair. Yes,
Thank you.
Thank you for inviting us to present to you tonight. We are really anxious to do so and welcome the opportunity and welcome the fact that the meeting is in public and are very pleased to see so many of the public here. This is an issue that affects everybody and we want to hear from everybody regarding their views. I'm going to hopefully speak very briefly initially and hand over to my colleague Ian Stidson. Were I to be a member of the public, I would be worried about press reports, and I just would wish to assure people of the facts on this slide. There are no plans to close an A&E at any of the 3 hospitals, and in all the options being discussed, there will continue to be an A&E at each hospital, and we will discuss what that may or may not mean later on. And we have no firm endpoints at present, and we will discuss what we mean by that later on. And it's really important that this is about the entire healthcare delivery in our region of 1.2 million people, and that clinicians are actively involved in leading the development. I hope you will feel that is the case. And on matters that are requiring public consultation, there will be public consultation. I thought I should say that right from the outset, because I can imagine that there is disquiet out there about those issues. And I thought I'd just put it up straight before my colleague Ian Stidson moves on with the presentation and starts to tell you what our thoughts are currently about the primary care and community changes that may occur in our region. So I'll hand straight over to Ian.
Thank you, Ronan. So I'm Ian Stidson. I'm the Accountable Officer for Castle Point and Rochford Clinical Commissioning Group. And I'd like to just take you through briefly some of the work and some of our thinking in terms of what is going to be happening in the community for healthcare, for the provision of patients and residents in our locality. And just to pick up on that point that Ronan said, what we are doing now is, as a system, working together to transform services for our patients And there's been a lot of discussion about what it means for the acute hospital, and that's right, and how acute hospitals will need to change into the future. But in tandem to that is the need to ask the question, how do we then change and transform the not-in-hospital services, the primary care services that you all will be receiving? You're all registered with general practice in our locality. How does that need to change as we go forward to deliver a more effective and seamless service to you that is joined up with the services provided at the interface between the community and acute? So why change? Why do we need to change? Everyone automatically says, well, it's all about the money. I mean, money is important, yes, but actually it's about what is happening in our communities and what's happening to our population. And we know that there is an increasing demand on our from our population in terms of health and care services. 81% of GPs report they are actually seeing patients with more complex conditions. Those such as diabetes, COPD, dementia, asthma, are more and more people are being seen. And that's because our population is getting older and living longer. And that's partly because we're able to intervene and provide more intensive and appropriate services at an earlier stage, so we can keep people healthier for a longer period of time. But actually, because we're doing that, our GPs, our primary care provision, are seeing more and more people on a yearly basis. If you link that to the rise in A&E, we have seen, particularly in our locality, a real hike up in the number of people using our A&E services, and the figures there are quite stark, where you see our numbers and how they've risen against the national average, which is 1.6%. But we here in Mid and South Essex have seen a 4.6 increase in activity. And that is a significant pressure, again, on services, and something that we will need to address and to find a different way of how we can deliver services for the population. We know that as we look forward that the demographics of our population are going to continue to get older. We're going to have more over 85-year-olds than we've ever had before in our community in the next 10, 15 years. And we need to be able to shape our services now to be fit for the future and to be sustainable to deliver services as we go forward. The other thing that we are acutely conscious of as we've gone through this process and are going through this process is that we are still too fragmented. And if I take the out of hospital services that we provide, the general practice, the community services, district nurses, pharmacists, dentists, they're not tied up, they're not linked up, and the service provision is still has gaps in between. And from a patient's perspective, your pathway of care does not always follow in a seamless way. And that's something we have to address. And we also have to address how then that then works into the hospital in a seamless way, and again out of the hospital back into the community. So that's a key component of what we're here to do. We know that our traditional workforce is not sustainable. Our current GP workforce are getting older, like the population, and they're already extremely stretched. Our clinicians, there's a huge demographic of particularly with GPs that, from our perspective, that are reaching 60, 65. And we know that in South East, but also in the rest of Essex and much wider across the country, the GPs are finding it increasingly difficult to secure new GPs within their practice. And I'm sure with you, you're all registered with practices. Many of you will probably have picked up that as a GP leaves a long-standing partner, it's not an automatic replacement, and GPs finding it more and more difficult to recruit and hold on to GPs for the future. We know that modern standards are being required for hospital specialists. We know that services are needing to be delivered over those 7 days a week, and how we would do that. That again adds pressure. And as I said, there is a huge recruitment pressure in our system. It's GPs, yes, but there's also issues around recruiting nurses. There's the change in terms of training for nurses that will probably feed into the system going forward. So we know that if we relied on recruitment and said to our system, we'll actually just keep going, keep putting the adverts out, that we would come to a halt. We have to find new ways of working, new teams of delivering services that are different but deep and resilient to those changes. So what is it that you have said? And this is quite a useful slide, I think, because through the process of engagement that we've been having with our public in Mid and South Essex, we've asked you, what are the things that actually need to improve across our system? And if you look at those top 12, where you start with, and it's often when I go to meetings, the first thing people ask me is about access, and access particularly to general practice. That does appear at the top there. So this is about how can we improve that access? How can we have a consistent service for our population through general practice? And that links again to community care as well, to our district nurses, to our health visitors, and the range of provision that we have across there. Prevention is also extremely important. And when I say prevention, I also mean self-care. And self-care really must start to play an important role in how we deliver our services, because the longer we can keep people healthier and the more engaged we can be with those individuals in terms of their own health, so we can delay and eliminate those unnecessary activity in the community services and into the hospital. So looking down those top 12, probably you won't come down to the hospital experience until near the end, and that's really interesting, because I think a lot of our debate and discussion today has been around the hospital, but actually what matters for the people that we've engaged with is much around social care within the community. So this is the overall plan, and it's 3 bubbles, and if you look in the bottom left-hand corner, what I'm talking about here is actually looking to transform and change how your local services are delivered, how your GP practice will change in how it delivers that service, how they will intervene differently, how they will work in a joined-up way. And by doing that, they will ensure that the top bubble will allow people to live well and live longer well. And be able to have their own plans, be confident in terms of what they need, have the treatment intervention at an earlier stage. And if we get that right, then we unblock the blockages that are currently in the hospital. So we take a proportion of people out of the system by intervening at an earlier stage for their local services and enabling them to live well. They won't need to go to hospital. They won't need to be at A&E or through non-elective activity, elective activity. And by allowing that to happen, the hospital then frees up resources that can then go back into primary care and be reinvested to really develop and strengthen our interventions that we can do in the community. So it's a circle, and we're all in it together, in hospital and out of hospital, and we can't do this on our own. So this diagram shows us the way we can do that. For just to give you a little flavour of how we are beginning to change primary care and out-of-hospital services in your locality. And this is from a Castle Point and Rochford perspective, but these type of things are happening throughout the breadth of Mid and South Essex. But we have now commissioned a local service for the population that is offering planned GP's appointment at weekends. And in the last year, we have delivered over 8,000 additional appointments to patients that were not in the system the previous year. But not only that, we've done it in a way where we've brought together practices to agree to say, well, actually, we will all sign up to directing our patients if they wish to have that service. So out of 25 practices, we have 20 practices signed up to this service, and we are planning to move to the full 25 by the end of the year. We have another element to take into account is the progress we've made is that we have divided our CCG into 4 localities: Rochford, Rayleigh, Castle Point, Canvey Island and Benfleet. And we have got GPs in those localities working together and saying, how can we change services for our population? What can we do, and how can we work together to deliver a more effective service? So we have now got those practices sitting around the table and saying, actually, let's start to change our workforce. Let's start to bring in new resources, new people, to actually take some of the burden off the GPs and allow the GPs to spend more time with those more complex patients. So we now have pharmacists that are employed across a locality that are working for those GPs. We have emergency care practitioners. The first one of those started probably about 4 months ago in Benfleet, that is now working across all those practices in Benfleet. We have advanced nurse practitioner. The first one that we've got has got the specialism in long-term conditions, and again is working across a series of practices. We've also implemented what we are calling care coordination, and this is a service where all our practices have identified the most complex and vulnerable of their patients, and we have commissioned a completely new service that is nurse-led, but actually involves social care and the voluntary sector, to take those individuals and to wrap a care plan around them and to intervene and give them a point of contact, so that if they do become vulnerable and if they do have a need, they have someone to contact and a range of services that can be delivered for them. That service has been in place now for over a year. We have 1,700 patients on that service that are linked in with the service and are making a real difference to their life and maintaining their health for longer, and actually doing one thing that we've never done before, and that is make the joining up, and we came to about the fragmented system, joining up how we work between health and social care. And that is a really essential piece of work that we're doing. We've also recognised that we had a pattern of provision across care homes that was a bit mixed up, really. So, one care home could have about 3 or 4 different practices linked into it, delivering slightly different services. So in Rayleigh, we now have in our care homes a dedicated practice that is delivering a service for those care homes. And they've been commissioned to deliver services, not your core general practice services, but a service that is designed to intervene and to look at the needs, again, of some of our most vulnerable patients, to ensure that those services, those patients have timely intervention and quick intervention. And by doing that, we're avoiding the need for those individuals to turn up at the hospital for interventions that could have been avoided. We're also looking at a number of different schemes across the county, across the CCG, around how we use, how we improve access for patients, telephone consultations, e-consultations, the use of texts for population. One of the biggest challenges when we look at the services we provide is the number of patients that do not turn up for appointments. It can be as much as 25% in some areas and some general practice. So you actually have general practice sitting there not seeing patients because those patients haven't turned up. through the use of technology, we are just piloting at this moment in time a system that will remind a patient that their appointment is happening the next day, but also allowing the patient to cancel the appointment directly on the back of the text. And as a result of that, it's freeing up a number of appointments in that practice, and that means that practice is able to see more patients on that day. I'll just leave you with one of the latest headlines that is happening in our area. In Audley Mills over in Rayleigh, it's a big practice, about 10 partners. They've taken quite a brave step in terms of transformation. They've said, well, actually, we're going to change our system so that everyone who phones up will get a triage from a doctor on the line on the day they call. And if through that triage process we decide actually the patient does need to come in to see us, we will see that patient on the day in our practice. So it's only been going a week, but we have seen the amount of contacts go up from 1,000 to 2,000. You might think, how on earth can that practice cope with that? Because of the efficiency of how the system is working, by the end of the week, the GPs are saying, actually, it's freed up more time for me. So even though I've had contact with more patients, I've been able to do more because of the way the system works. So we're going to be watching that with great interest to see how that sort of beds down in our community, listening to patients' experience, etc., etc. But I think I'd leave it there, because these are the type of things that we will be doing to transform how services are delivered for you as patients in your locality. It will be based around localities. It will be based on GPs working together effectively with social care, with the voluntary sector, and with a wider and deeper workforce in general practice. So I think that summarises where we are going with health and care, and I think I now hand over to Ronan again.
Thank you, Ian. Sorry, just working the technology here. Thanks very much. And we see the slide again describing sort of in a very broad brush picture what is proposed. And I think it's really important to realise that the majority of our contact as patients with the health service is not in hospital. And that is why on those 12 points that hospital came down number 12. But the work that Ian and colleagues are doing in what we call the out-of-hospital bit is actually crucial to how you and I will receive healthcare in the future. Carolyn and I both work in hospitals, and to us that's our life. And I'm here to tell you about what our thoughts have been over the last about year and a half as we've worked with many, many people to try and think of how we might alter and improve our hospital services for the future. And in broad terms, the bottom right-hand corner does give a little taste that we do feel it's important to try and separate emergency care from planned care, to recognise that some specialist emergency treatments are better delivered in specialist centres, and to streamline specialist care. But overall, let's just see, what we did at the very beginning is we said, you know, looking at what we have, because we don't have a blank sheet of paper, what actually are we able to move around? And we came to a conclusion very early on that there were a few things, we called them givens. But for example, if you go to Southend right now, there is a fantastic radiotherapy and cancer service there. There's a radiotherapy suite, and if you knew about building radiotherapy suites, you'd realise that's a pretty major piece of kit. It would be pointless jacking that up on wheels and moving it to Broomfield or Basildon. Similarly, we've got a cardiothoracic centre in Basildon, and apart from the building itself, the teamwork that has developed there and the systems that have developed there, we recognise there was no point in moving that. And we also felt the same for the tertiary referral service that exists at Broomfield for burns and plastic surgery. So at the very beginning, we kind of felt that they were things that would remain. And that decision actually does impact on what else wraps around them, because and that's kind of an important thing to remember. That's what we did right at the beginning for those reasons. We did feel that at all sites there should be 24-hour A&E, and we'll discuss what that means in a while. We did feel that as well as that, and it was interesting to hear a colleague mention that someone has gone to an assessment centre, we feel that at each of the 3 sites there should be what are called medical and surgical assessment units, frailty assessment units, because that is a huge factor of our healthcare need at present, the elderly and the frail, and we will all be in that number, hopefully, one day. But we need specialist attention, and we think a unit such as that should be available at all 3 sites, a children's assessment unit at all 3 sites for management of the initial presentation of ill children. All sites will continue to have outpatient clinics, day surgery, maternity as they do now, and they would need, if we move things around and reconfigure, they would need to be able to repatriate patients who have perhaps gone to other sites for their specialist treatment. That's what we thought around initially. What does that actually mean? And actually, it means not a lot of change for the majority of things that people currently go to hospitals for. In most of our modelling, it kind of means about a 5% change. And I say that not to lull you into a false sense of security so you can say, well, it's okay, nothing is going to change, but just to give you an idea of the scale, because we feel something has to change. And if I put everybody to sleep in this room, and I could actually, right now, and you woke up 5 years later, what we would hope is that you would say, and you had to interact, gosh, this is different than it was 5 years ago, and more importantly, this is better than it was 5 years ago, and I don't want to go back 5 years. That's the aim of large-scale change that we're after. So even though from a hospital perspective I put it at 5%, and that still impacts quite a lot on the care delivered. Now we spent a lot of time over a year and a half discussing what potentially this would mean for our 3 hospitals in terms of their configuration, what would go where, and one of the key questions was how would specialised services be delivered by the 3 hospitals. And we came up with a concept of the possibility of 3 different types of hospitals delivering specialist care in 3 different manners. One would be a hospital that really focused on emergency care, specialised emergency care for the sickest people who need it there and then. That would be the job of one hospital, and that was in line with national guidance. And you will see a slide in a minute that shows that outlined as a red hospital, and we just use the colour red to help us discuss it, and you will see that shortly. We felt that another type of hospital would be one that would balance that as well as elective, and elective care means planned care. It means me being told, Ronan, you're going to hospital next week to have a new hip. That's a planned event. So that hospital would be able to do emergency care as per the red hospital, but also the planned. And then we had the concept of a yellow hospital, and that would be one that would focus mainly on the planned care, because one of the things we are very aware of is that the planned care, because of the load on the emergency care, gets pushed aside continually, which for the individual patient is a dreadful patient experience. You come in and they say, Ronan, I'm sorry, we can't do your operation today because there is no bed. And you say, well, I understand perfectly. I know there's an ill patient in there. But still, it impacts on you, your life, your family, everything, and impacts on the economic use of the resource, because that theatre is idle during that. That's a resource that you and I are paying for at that time. And the concept of the yellow hospital is one that could be spared from the impact of the emergency load so that it could focus on providing the care for the elective patients less cancelled operations, more efficient use of resource, and it rolls on. Now, when you consider those three types of hospitals and you try and distribute them in various ways around the three hospitals that we have, you get a diagram such as this. And you can see that for the three hospitals we have, we said, well, what if Basildon was red, Broomfield was orange, and actually we didn't have a yellow and Southend was orange. And at the very bottom you see, what if Basildon was orange, Broomfield was red, and Southend was yellow. And those are the permutations and combinations of those three concepts in our area. We actually went a step further with this, and we said, you know what, there are a lot of permutations and combinations there. This is large-scale change. If there was to be a preference, what would it be? And we convened an appraisals option process with external stakeholders, with local clinicians, with patient representatives, quite a thorough process. And actually from that process they said, if you were to focus on any two, because it might be easier to do so, they would suggest focusing primarily on 2A, which has Basildon as the red, Broomfield as the orange, Southend as the yellow, or from the 1A, which has no yellow, the one section which is no yellow, focusing on 1A, which is Basildon as the red, Broomfield and Southend as the orange. That was what came from that appraisals option process. Now, that's where we are on this concept right now. And that's the work of hours of meetings, hours of groups getting together and discussing what actually is possible. And it really, and many, many clinicians actively involved in the process. And it's really important to listen to what I've just said. Many, many clinicians actively involved. And it's also important for you to know and to appreciate that it doesn't mean that all clinicians are totally comfortable with this. This is big change. Any of these represent big change. And it is A, not surprising, B, appropriate, and C, comforting that actually within the clinical body, and in many respects, Caroline and I represent probably, or don't represent, but we stand as a bunch of, I don't know, about 900 consultants, probably 5,000 nurses. That's the clinical body that you're talking about. And some of them, like some of you, are not comfortable with this, and that's good. Because what that does is it pushes us to reevaluate and take it bit by bit as we move it forward. And rather than feel frightened by that, I would advise you to feel comforted by that fact. What does it mean, in my view, from an A&E perspective? Because I think that's the question people want to know. To me, any of these permutations and combinations would mean that all three areas would have an A&E, that those A&Es would be capable of dealing with the presentation, the emergency presentation of any, that as right now, with any illness, they would be capable of dealing with the emergency presentation, stabilizing them, and then triaging and sending that patient on to where it is necessary to send them, be that home or into the hospital, as happens now in all our hospitals, or, as also happens now, by the way, on for many occasions, actually, you know what, this patient would better be treated in another one of our hospitals. And that happens right now for many conditions. And obviously, all of that depends on close working with primary care, close working with the East of England Ambulance Service from a transport point of view. But that's how I see it. And I think it's important to know that not everybody sees it like that. And I know my colleague Caroline doesn't. And so I think it's right that you hear Caroline express her views on this. Is that all right, Caroline? Yeah.
Okay, so as Ronan has said, we certainly have been working for about 18 months as part of the success regime with various meetings, and that has involved both myself as the lead clinician in Southend A&E, meeting with the lead clinicians based at Broomfield and at Basildon, and with a lot of our other members of staff as well, so with our lead nurses and managers. My concerns arise really because from my point of view, and I can say I'm here representing both of the lead clinicians from Broomfield and Basildon as well, that we do not agree with what has been put forward on the options appraisal. We categorically stated we did not agree with the development of a specialist or RED hospital for accident and emergency, and that was after working through those meetings for a number of months, and there's a number of reasons behind that. We don't feel it addresses many of the issues that should be addressed, would hopefully be addressed, and in honesty there are not some solutions to those that are available at this moment in time either. We felt, from our point of view, you've heard about complex elderly and frailty needs, and really from our point of view that is what is affecting how emergency departments function at this moment in time. So the problem that we have functioning as an emergency department is that once we've seen a patient and we want to admit them, there is nowhere in the hospital for them to go to. Looking at all of this and whether we have red, orange, yellow, whatever type of hospitals we have, the bottom line still exists that we don't have enough medical frailty beds on any of the sites. There will always be overspill into what are elective areas. So without the community coming up trumps first and dealing with that ever-growing population, we don't see it solving actually the crux of the matter. And the crux of the matter is not how the emergency departments are functioning, it's about how we prevent elderly people coming into hospital, how we, in effect, turn them around quickly so they aren't in hospital for a long time, and how we stop them coming back again, because that's a major problem. And we don't feel that this answers any of those problems. There are definitely problems from an A&E point of view. You've heard staffing being mentioned. And we are concerned that this is stated to address the staffing. When we look at what staffing you need to staff a red, an orange and a yellow hospital, you actually end up needing more staff. You end up needing more A&E consultants, because the intensity of such what would happen at Basildon Hospital, you actually do need 24/7 consultant cover there, as well as we're being told we've got 24/7 A&Es on both the other two sites. Again, we are shuffling numbers between 3 sites. We aren't increasing that in any way. The definition of a 24/7 A&E has also been a concern of ours. So if you look at the various orange and yellow hospital options, they would involve ambulances bypassing that hospital, either in totality or in certain hours of the day. As an A&E doctor who went into A&E because I love it and because I actually want to see acutely ill people, I would not work at a yellow hospital because it doesn't bring me what I need. No other A&E consultant would work at a yellow hospital. That's not what they've trained for. That's not what they want to see. So to say that there will be a 24/7 A&E on each site, I think is a misnomer. And again, from the success regime meetings, we felt that actually we should be honest here and we should be saying that that will result in a downgrade to a walk-in centre. If it doesn't, we actually feel that will be more dangerous. At the moment, if someone walks in, and we do have a high number of walk-ins with serious medical pathology at Southend, we are able to manage them, recognise them, treat them, because that's what we do with the 70 to 100 ambulances that we have a day coming anyway. If we don't have those 70 to 100 ambulances coming a day, we are not going to be used to recognising, treating and managing patients with serious pathology. They are going to have a worse outcome. They're not going to do as well. So we actually felt as a group that you could not call this an A&E, you should not call this an A&E, and you should call it a walking centre. The concern, and from our point of view, calling this a specialist A&E, a red centre, is that there are groups of patients that do better by going to specialist units. Absolutely, hands up, the evidence is out there. However, that already happens. I'm quite happy to talk in detail, and I don't want to get into medical jargon, but there are groups of patients that do better by going to a specialist centre. Some of those you are able to identify them pre-hospitally. So you will hear that patients with a heart attack already go to Basildon. The truth is that a small percentage of patients that have a heart attack, that equates to about 2 patients per week, have a diagnostic ECG which the paramedics can do, and then they can take them direct to the cardiothoracic centre. Of note, they do not go to Basildon A&E, they go to the cardiothoracic centre. That pathway is already in place. The same exists for other conditions because we know that. So actually, for better outcomes, the evidence is there, the change has already been made, that's all in action. The concern from a clinical point of view is actually the evidence shows the longer you travel, the more likely you are to die. And for every 10 kilometres you travel, the best UK evidence shows you have a 1% higher risk of dying. And if you have a respiratory problem, which Southend again has a very high respiratory illness rate, and we've already mentioned the COPD and asthma's complex problems, that's 2%. So my concern is, as a clinician, I'm told to do the best by my patients. This is not the best by my patients. Now, the good side is absolutely we need to be working together. There are definitely positives to be had here. There's definitely improvements to be made here. But my concern is that we haven't been listened to. We have come up with alternatives which we feel are better for patients, and we're very concerned that the 5 options left on the options appraisal are not what we have supported.
Thanks, Caroline. Thanks, Caroline. You're probably really surprised to hear that, and I'm really glad Caroline has spoken, because what you see in front of you are 2 people who are passionate about making things better. Both of us are passionate. What isn't at issue here is who's right. Because actually, I might be wrong, Caroline might be wrong, but one thing you can be assured of is that we are people, both of us, who want to do it right. And we intend to work together and do it step by step, bit by bit, not turn on anything if it doesn't make sense to do so, and if on testing it doesn't work. Because actually, I believe in this, I really do. Caroline and some of her colleagues don't. And that's what you've heard, and we've been very honest here tonight, and it's really important to be so. And rather than going out the door frightened, I would suggest you go out the door saying, it's good to see 2 professionals who are willing to stand up and give 2 different views and work together, because that's what we'll do. And we will do it step by step. We will actually take a phased approach to any change. And where we will get to at the end of this process, I actually don't know. I think, personally, that it would be very good to get to one of those, in fact, end results. But that's just me. Caroline has a view which is very valid. And we may end up somewhere in between. But one thing I guarantee you, we will be working together, and we will be making sure whatever we do ends up the best for patients. Because that's what we do. And it is not a surprise that there is disagreement amongst professionals on this. This is big stuff. This is hard stuff. And anybody involved in large-scale change will, and I'm sure, as councillors, you yourself have been involved in many types of change and rarely had the luxury of a unanimous agreement amongst you, and may have come to a better agreement because of that. And that's what I hope will come out of this. So I'll hand on to Tom now, who will take you through some more.
Thank you very much. So I'm Tom Abel. I'm one of the executive directors.
Can we ask you to turn his mic on,
Is
please?
that working? Okay, fine, great. So I'm Tom Abel. I'm one of the executive directors now responsible for Southend, Basildon and Broomfield hospitals. And I think from the board of the 3 organisations, we're absolutely committed to getting this right. And one of the things that we recognise that we need to do, and the conversation that we've had just now around some of the issues and concerns around our current proposals, is that we need to listen. And we need to listen not only to our clinicians, but we also need to listen to our communities. And their concerns and worries and issues. And we are absolutely committed to doing that over the course of this summer. And this is one of many opportunities that we have to hear your views and your concerns and to help us inform our ideas. So, given where we're currently at, given the concerns that there currently are and the work that clearly needs to be done and to work through at a more detailed level what our end proposals will be within any sort of public consultation, we're doing two things. So the first thing is continuing to work with Ian and the other colleagues across the other commissioning groups across Mid and South Essex to really help them accelerate some of these developments outside of the hospital, because we know that actually the key in terms of getting our hospitals and so they're delivering kind of safe and effective services all of the time, as Caroline said, is by beginning to manage frail older people better. The second is the work that we need to do in the hospital, and that work is around us beginning to better articulate what are our proposals on an individual condition-specific level. And so what we're doing, we've set up a clinical reference group made up of senior clinicians from the three organisations, which is shortly going to be meeting. And then we've also are initiating 4 groups to work through what we describe as blueprints. And what I mean by blueprints are happens when you turn up at any hospital and what changes might there be which would deliver a benefit to patients that we would then consult on. And those 4 groups are a group focusing on our kind of emergency care and the functionality of each of the A&E departments of the 3 hospitals. The second is around how do we address some of the issues that Caroline has just described around our core general medicine and surgical emergency admissions. The third is, are there any things that we can do around better separating some of our planned care so we are not in a position where we are cancelling as many patients as Ronan's described. And the final area is around paediatrics, and so that's work that we need to do. And that work will be led by senior clinicians from across the 3 hospitals, working it through on a patient condition by patient condition level. So, given that, we, in terms of the timescales around when things will happen and when we will get to the point where we've got some final proposals, we've got some time. So, we are continuing the local discussions that we've had to date and will continue to have with our local communities and with our clinicians, and that will run through to September this year, we currently anticipate. We then have to complete something called a pre-consultation business case, because we have to go through a national assurance process on any proposals that we make, which goes through NHS England, which is one of our regulators. We then have to go through that assurance process, and that will also include working with the 3 local authority scrutiny committees, and then we would then initiate a consultation programme. And so at the moment, we think the formal public consultation activity would start in December of this year and run through to March 2018. There'll be analysis, obviously, of all of the feedback that we've had on our proposals from local people, and we would refine those proposals based on that feedback. And so we currently anticipate that a decision would be made in May 2018. So that's our current timeframes. And so what I want to assure you from this is we're not going to rush this. We need to get it right, and we need to make sure that we've had enough time to work through the proposals in the right level of detail so that both our clinical teams are comfortable with whatever it is that we propose, but equally also you and the communities of Mid and South Essex are comfortable with what we propose. So I think that's everything that we were going to talk, and I think we're happy to open up to questions.
Yeah, I'd like to say thank you. That's it was quite a good presentation. I'm sure we've got lots of questions, or I would assume we've got questions. What I would say at this stage, can we have one question from each of you, so that to start with, so that I can then go around and everybody gets a chance to speak. But it doesn't mean to say I'm not going to come back to you, please. Councillor Cutmore.
That's it. These things don't work unless you turn the other one off, unfortunately. Thank you for the presentation. I can't say I'm terribly reassured by what I've seen, because you haven't really made any decisions yet, or at least the decisions that you seem to be wanting to make do cause problems, I think, for local people. And clearly local people, particularly in Rochford, where you've closed the hospital already, have real concerns about how we're going to carry forward. One of the things, and I'll just ask one question, if I may, because I'm sure there are other questions that will come forward, but this actually came from our Member of Parliament, because as far as transporting people around is concerned, there is a lack of ambulance from the East of England ambulance already. Now, if we are involving ambulances in longer journeys, can you assure us that part of the equation is to actually increase the ambulance service and to take on the right people with the right skills to actually staff those ambulances?
Yes. We couldn't possibly do this without involving East of England Ambulance. They are involved in the process. The issues that you bring up are exactly the issues that they speak to us about. There would be no point in suggesting that we could do this without them upskilling, changing how they operate, so they are part of the process. It's not a simple equation, but we wouldn't operationalise any of what I have outlined without that being very much part of the equation.
Councillor Gooding, please.
Thank you, Chair. On the 8th of November, Ian Stitson done a presentation to the councillors where I raised concerns about the agency staffing, which is obviously costing far more to taxpayers, and I was advised that there will be staffing coming in from Spain and the Philippines to bridge this gap. Are you able to confirm, Dr. Howard, that this has happened?
I'm not certain what particular specialties they will be talking about, whether it was accident and emergency. There are, that part of Nationwide, there are shortages in A&Es. Unfortunately, it's not a popular specialty to work in. The latest figures I had was from our Royal College, which is sort of manages every A&E in the country, that 2 years ago 50% of all consultant or senior registrar posts were vacant in the UK, and that's the situation we were looking at. At Southend, actually, we are one of the best staffed departments for senior registrars in the country at all. From a nursing point of view, there has been some nursing recruitment from the EU, from the Philippines. I would still say that staffing is probably the #1 problem for all 3 hospitals. Probably, I can't speak for all of them, but probably most hospitals in the UK.
From a Broomfield perspective, which is the hospital I probably know best, I know that we have increased our nursing staff over the last 5 years, quite substantially actually, and managed that through international recruitment at times. And much of that has been driven by increased standards and requirements for more nurses. But there is constantly a flux, and there is constantly, we would never be at full establishment. That's not uncommon.
Ian Stitson, you wanted to answer.
Yes. So just to feed back to you, because obviously this cuts across all our organisations, and the hospital has just given an explanation about what's happening from the hospital side. From a primary care side, we also have an initiative to attract 50 GPs from the EU into Mid and South Essex. That recruitment process has started, and I'm pleased to say that we have already established 8 GPs are being placed within general practice within Mid and South Essex. So we are beginning to get more GPs from that route. Now that isn't the answer, because obviously we've got to change how general practice works, and we've got to attract the GPs we have got in this country into South East Essex. We believe that by taking this fresh approach in terms of how we deliver primary care, we will attract GPs into this area. So it is not the solution, but it helps in terms of our short-term planning to ensure we deliver effective and fast treatment for you in primary care.
Councillor Mr High, please.
Thank you, Chairman. I think people need to go first. I've always wondered what would happen if I asked for a second opinion for a doctor, and I now know. I think I would guess my inclination would be go to the one that I believe best expresses the same concerns that I would have, which I assume is why you asked for a second opinion. And I think Dr Howard probably, with what she has said today, encompasses all of the concerns that I have had, and perhaps introduced a few more. I did have a lot of questions, which I think everyone else has, but hopefully other people will pick up other questions. I just wondered, I think a lot of the presentation I'm very happy with. I agree with things that Mr Stibston said, and I believe that's the way forward. And I think a lot of the concerns are around what Dr Howard said. And I just wonder if we don't go the route that Dr Fenton has suggested with A&E, how you would, Dr Howard would view what the alternative is, to stay as we are, or would it be slightly different? I just wondered what that would be. Thank you.
Well, as I said, I've been involved probably 18 months now with since the success regime was announced, and that has meant that we are working closer together across the 3 sites, which I think is a good thing. The kind of the model that the free clinical leads for the sites are looking at is what we would call a treat and transfer model. So each A&E would continue to receive the patients that they receive now. Those that we do send off elsewhere, so such as that the 2-a-week heart attacks to the cardiothoracic centre, would still go there. We would then treat and stabilise and diagnose those patients, and I think it is important, and I have discussed directly with the Eastern Ambulance Service lead that was involved in the success regime, and I don't want to appear derogatory to them at all, but they are not able to diagnose these patients and pick out the ones before they get to hospital, and he was in total agreement with me with that. Once we then had a diagnosis, we would then look at what patients would do better either going to a specialist unit, or what patients it would make sense from a service provision would go to a specialist unit. So a good example of that was some patients will have a gastrointestinal bleed, a bleed from the gut. The sort of the proposal of transferring them many miles while they can't be stabilised, essentially, you know, they need certain drugs, they need a blood transfusion, they need clotting factors, etc. So to propose to transfer them further would result in a higher mortality. If they would go to their local A&E where they go now, they would receive all that and be stabilised. Now at the moment, in all 3 hospital sites, there is a GI bleed on-call rota. Now, I think anecdotally, and I don't have the figures for it hands up, but anecdotally, probably 2 patients a month at Southend go for an emergency GI procedure overnight. Now that doesn't make sense, therefore, to have 3 different on-call rotas across the 3 sites. What would make sense is to have one place on call, or even the possibility of a mobile GI on-call team that go to where the patient is. That would make sense from a lifestyle, from a rota point of view, manpower, and for a safety for the patient point of view. So that is the proposal that us as the lead clinicians would put in. We would work out what patients really needed that specialist emergency input and how that would happen.
And it's worth saying that that's exactly our first step.
Sorry, could that be, is that the first step on the plan that you like? Is that what you mean? Sorry.
Well, as I indicated, because of the clinical worry that does exist, We are taking this in a step-by-step approach, and to see how this model would work out would be our first step, because it would be an improvement on what we have at present. Whether it actually will create the difference we need is another question, but it's an example of us listening and working together. So the worry you have, which I understand, you know, faced with two people, but I'd like to reassure you that we are actually working together. And as professionals, we can disagree, but we can also come together.
Councillor Ward.
Thank you, Chairman. Well, I am on, if you can hear me. You know, it's kind of worrying at times, but I was interested in the points that both Dr. Howard and Dr. Fenton have made. The collateral damage concept and where that's being modelled in, that you're bringing up, where if you've got distances to travel, that's extremely worrying, and I wonder if that's been put into the modelling and what is an acceptable percentage for such collateral damage that may come up. But my main question was going to be on bed blocking, which I think is a major national issue, and I've sort of had personal experience of this with my mother-in-law in Southend Hospital, where she was in there and they couldn't find, you know, a place for her to go. And this was extremely difficult, going back to her place and the care. And one of the things, there seems to be a lot of confusion between clinical and social care. Whether you need the clinical help or whether you're going to get the social help. And this seems to be a big problem which causes anxiety. I wonder how much that's going to be addressed. And the point that you brought up as well was with regard, which I found was interesting, if someone is actually going to either Broomfield, they live in Rayleigh or they live in Great Wakering, there was something in your mentality which is saying that as soon as they are on the recovery, the road to recovery, you're going to try and repatriate them back for, you know, literally recuperation to the nearest hospital. Was that something that you were trying to get across, or not? I'm just confused about that. Yeah.
So sort of two things. What you term as bed blocking, which is an unfortunate term, because actually these are patients who are in an unfortunate position at the time. And you're absolutely right. And as Caroline stated, the actual flow through the system is the big problem. And the ability, and this is what Ian and his colleagues are trying to address, that's why it has to be a whole system process. The ability to find appropriate social care for patients who need it and reablement is critical to achieving this. And at any one time, I imagine in all of our three hospitals, I don't think I'd be far wrong in saying there is an entire ward with patients in it who could be elsewhere, and that it would be beneficial, and that's exactly what my colleagues are trying to deal with. With respect to the transferring, I mention it because in some models it is the case, and I'm not suggesting it would be the case in ours, but we have to consider it, that the initial acute treatment of a patient may occur in one centre, and this happens. And, for example, a trauma patient, and this is an extreme example, who is treated in Edinburgh, for example, right now, once they are stabilised there, they are repatriated to one of our hospitals. That's one such mechanism. And my wish was just to point out that as a pathway it exists, and it may be a pathway that we would want to employ.
I think this is a great concern as well from the repatriation point of view, and also for these frail elderly people, the possibility of taking them away from their support network as well. We know for elderly people, I actually am also the clinical director of medicine now, we know for elderly people that if we do transfer them just from ward to ward, that has detrimental effects on their length of stay, and also can cause a deterioration, particularly in those with dementia, because you're taking them from somewhere very unfamiliar and now putting them somewhere else very unfamiliar. So the actual factor of then transferring them across hospital, I don't think has been fully accounted for, and the effect that will have on the overall length of stay, and therefore the bed blocking process that you comment on as well. My concern would be that would increase even further.
Simpson.
Yeah. So just to come back to you, this is a whole system thing we've got to look at. So you can't do one in isolation without the other. And part of the getting individuals out of the hospital, we have to look closely and in a different way in terms of how health and social care work together to ensure that we've got the right placements in the right place at a range of, because people are coming out with a range of complexity. But you can't look at this in isolation. There's the avoiding people going in, there's the treatment, and the people coming out. And the one thing that we can do across the success regime, the STP, is ensure that we're looking at it together as a whole system and find effective ways of reducing instances like you've just given us.
Thank you. I appreciate that some people are wanting to come back with second questions, but I've still got quite a long list of those with their first questions. So next one, Councillor Hookway, please.
Thank you, Madam Chairman. I was just wondering how the experts here see what they're looking to do in regards to an ever-increasing population, and in particular in this area, which seems to be rising quite significantly, and how that's going to affect your services and the provision of your services going forward. If you're looking into the long term, you know, into 5-10 years, you know, the population changes in that time are going to be quite significant. And on that basis, you mentioned that GP services are quite crucial to how people interact with the hospitals. And there's been mention that looking to get GPs in from other areas and even other countries. But what are we doing as Southend University Hospital and other hospitals around the country to get our own GPs from our own populace through the system and into practice to replace the ageing GPs who are looking to retire at some point? I think we need to really focus on providing those sort of specialists from our own population. And just one point about local situation. St Luke's Drop-In Centre has been closed and has been closed for a little while now. Now, that is a facility that I've actually used myself and found it was quite handy for me because of the situation in my work made it difficult for me to get an ordinary GP's appointment. Now, it would seem that that particular service is a service that would have prevented some of the impact on the A&E departments. Now, surely you should be looking to provide services like that rather than take them away. Thank you.
Thank you for that. So if I just address the first thing around attracting new GPs into the locality. I think there is quite an exciting development that's happening at ARU, where there is a new medical school being developed, which will have links in Essex. So I think that is a component of actually bringing GPs into Essex and keeping them in Essex. Where we have training practices and we bring individuals in to be training to become GPs, we know that they stay in Essex a lot more than those that are coming from the outside. So I think there is a real movement in Essex to train and develop the new general practitioners for the future, and we will tap into that very strongly. I think part of this is around how we can change how our general practice works, because I think my experience is when you go into general practice and speak to GPs, they love their job, but they're just so overburdened with the pressure. And we've got to find a way to take the pressure off of them and change that primary care provision. And we are starting to do that. And we are starting to, where we are bringing more professionals working in general practice, working across general practice, it is starting to free up the time. If you then take that step further and actually say, well, actually, how can these group of practices then support each other, still retaining their own identity and the services they deliver, and actually start to say, well, actually, you may have a GP that's got a specialism in diabetes, that has a team associated with it, that patients could be seen there while still being seen or under their own GP. You're actually taking pressure, you're shifting how services are delivered, and you're making general practice again an attractive place to come, to work and to stay. So you've got that level, you've got the level of training practices, and you've got obviously that wealth of people, the nurses, that we can use more effectively and more trained up to deliver more services for general practice. In terms of St Luke's, obviously that was a Southend CCG Commission service. Clearly, the decision was taken to close St Luke's down, and it didn't have the impact on A&E that some people were concerned it was going to have. What, in fact, you were happening at St Luke's was you have a number of activity that we were paying for, in effect, twice, because individuals were registering with another practice, but still using the St Luke's practice as a walk-in. Not everyone. So there was that component that we needed, at that time for Southend CCG, needed to make that decision. But of course, we are looking at urgent care out of hospital, and that is perhaps a component that was within St Luke's that can be then looked at and fine-tuned to be delivered more effectively for the locality. I think there are lots of lessons we can learn from that. I mean, it is done, and those walk-in centres across the length and breadth of the country were closing down. I think they were originally set up, if you remember, for those that were around, they were called Darcy centres, and every area had to have. I think there are components of that service that could be refocused as we start to reshape a service for a locality that may look different for those localities that are near a hospital to those that are further.
I would add that I think the Anglia Ruskin Medical School will be a real benefit to the Essex health community, and the problem from my point of view is that the GPs coming out of that will be a 10-year plan to get through medical school and then train as a GP, so it's not going to be an immediate answer. My concern would remain that from Anglia Ruskin's Medical School's own literature, they will say that we have the second highest number of vacancies of GPs in the area and the second highest number of GPs that are due to retire in the next 5 years. So actually I think things are going to get a lot worse before they can get better. And I think anything that's been presented today and anything that happens requires that community sorting, if you like, beforehand, because at the moment that's what's really crippling the whole of the health service in Essex at this moment in time.
Councillor Mrs High.
Hi, yeah, I've got a question for Dr Howard. Has the removal of the nurses' bursary caused a reduction in applicants to train as nurses, and are there any of these proposals dependent on having more nurses?
From what I understand so far, that yes, there's been a significant reduction in the number of nursing applications. I think I heard 60%, is that what you've heard?
Yeah, I think
60% number of reductions. It greatly concerns me because every hospital in the country has a large number of nursing vacancies. As I've mentioned, I also head the medical directorate now as well, and at the moment vacancies as we speak, which is very, very difficult to manage, and it means that there's a lot of extra work for the nurses that are there, so retention becomes a problem. Looking at the individual modelling, certainly if we look at sort of downgrading to a yellow and going along the lines of actually not calling it an A&E but calling it a walk-in centre and having it run by emergency nurse practitioners, you would need a significant increase in that. If you look at the red centre, so increasing its number of patients that attend there, so an example at the moment is Basildon figures. I think the last ones I saw where they have 130,000 attendances per year. Looking at the success regime figures in 4 years' time, that will be 220,000. So to manage those number of patients, yes, there will be a reduction on another site. But at the moment, for example, I have one majors area, and that has one majors nurse in charge and one majors coordinator. I couldn't double the size of my A&E and still have one nurse in charge and one majors coordinator. So whilst the proportion of actual nurses to the cubicles, like nurses to beds on a ward, would remain the same, I would need a few more chiefs to run the shop floor, so I'd be concerned that more are needed.
Councillor Eaves is next on my list.
Thank you very much everyone for coming here tonight. And very slick presentation. But I was with you until we got to the hospital side of things, and I think that is the general concern of the public on this one. To give you a little background, I was the first responder with Essex Ambulance, as we was at the time, 10 years, and one of the things that was drummed into me is that minutes count, as Dr. Howard has said. I would like to ask each of the representatives from the NHS here tonight to give me a one-word answer for the record as to whether you think that clinical excellence in response times is going to get worse or better by putting Red Hospital into place, categorising Basildon and the other hospitals in so as they take the emergency care differently. Is it going to be better or worse by categorising these hospitals for taking in the A&E? I'm not sure if I'm clear on that one.
You mean the outcomes will be better?
Outcome of
The outcome, yes, sorry.
Worse.
Better.
We don't know the outcome fully yet of what it is, but the aim will always be to be better. Whatever we express, the aim is to be better.
Thank you. Councillor Shaw.
My question is regarding the IT systems for all the 3 hospitals. Often we hear from family and friends, oh, I've gone to the hospital, they can't find my blood test, they can't find this test results. If you're going to shift patients here, there and everywhere to specialist units, will you have their records to hand? That's my biggest concern. I don't know who can answer that, if it's yourselves, or I don't think the doctors can. Thank you.
So that's a huge piece of work that we've already started working on. Just to give you an example of something that we've done already. So with radiology imaging, we have completed the process. So we now have a single what's described as a PAC system, which means that we can access the same system across the 3 sites. There'll be a lot more work that we need to do in test results, medical records, and to make sure across the 3 hospitals. We're not there yet, but that's all work which will have to be done prior to a number of these changes being able to happen.
I would add that regardless of whatever model we end up with, we should be doing that anyway, because you might live near Basildon, but you might work near Southend, and you might become ill in Southend rather than Basildon, so we need to do that anyway.
Thank you. Councillor Sperring, I know you've been waiting a long time.
Thank you, Chairman. While this is obviously an early part of the consultation process and having listened to the presentations, it seems to me that some of the issues and concerns that Dr. Howard has expressed have already been taken off the table, and so effectively implies that some of the opposition views have already been dismissed, and really the public has had no opportunity to review these comments in full.
That's my very point, and that is the reason we're both sitting here. Nothing has been taken off the table, and in a way, when I say it will be better, I agree entirely with Tom. We will do nothing that isn't better. Therefore, if we find that red isn't better, we won't get there. But none of Dr. Howard's concerns, and we discussed them quite openly, continually, are off the table, which is why we're actually right now working on the treat and transfer model and working bit by bit, because some of Dr. Howard's concerns will turn out to be real, Some of my views will turn out to be incorrect. Some of Dr. Howard's views will turn out to be incorrect, and some of my views will turn out to be right, or whatever. But we will work it through. That's how we function. So no, it hasn't been taken off the table, and there has not been a lack of opportunity for consultation. We haven't actually started the official consultation process, and we've already spoken at over 100 events in the last 6 or 12 months.
So if I could just add to that, so we're doing something quite unusual in the way that we're undertaking this. So if you look at the sort of the slightly inglorious history of NHS consultations, the way that if you say take London as a good example actually, or perhaps a bad example, in that what's happened is a whole set of proposals have jumped out at the last minute, gone straight to public consultation, and it's felt very rushed for local communities and that people haven't been able to have their say. We aren't doing that in this case. So what we are doing, we are keeping you updated as we're going along, and as we go along and as we listen to your views, as we listen to the views, we are changing and iterating our model. And so hopefully whatever we get to in December actually is something that you recognise and you understand more about than you would have done had we followed kind of the old way of doing public consultations within the health service, whereby we wouldn't have said anything and then December would have jumped out at us and there'd been a whole set of proposals which you didn't understand, weren't clear about, and you wouldn't have enough time to think about and to give your informed views to. So this is the way that we have deliberately decided to approach this work, to be open and transparent. But as a result of being open and transparent in the way that we have done this, it does mean that there's more uncertainty and the position moves over time. And that's a good thing, because that shows that what we are doing is we are trying to listen, we are trying to adapt our processes, we are working to engage to resolve those concerns and to moderate our proposals as we go along this process. So in terms of the way that we're doing it, which means that we can't answer every question now, but we can tell you where we're at.
I've got Councillor Chris Black next.
Thank you, Madam Chairman. One of the most enlightening council meetings I've been to, and I go back to 1984 here, and I can tell the difference between the good ones and the bad ones. I've learnt a lot tonight. I'm not clear on a couple of things. This is not my question, this is what I'm not clear on. I'm not clear on why the good work that Mr. Stinson's doing with GPs is linked with downgrading A&E. I don't know why the two things are even in the same document. Okay. Secondly, I was very interested to hear from Dr. Howard that the 3 clinical leads at the hospitals believe that are basically against the red and orange and yellow model and in favour of the treat and transfer. And if I knew what the definition of a clinical lead was, I would be even more concerned, I think, and perhaps that could be explained in the meeting. My question, though, actually, which is separate from most of them tonight, is from Mr. Stinson, and it's not even about directly about Mid and South Essex, it's about North Essex. Because you were talking about GPs being under pressure and difficult to attract new GPs, and that's partly to do with money. Now, I know that somebody, an acquaintance of mine, did a freedom of information request into 2 GP practices in the north of Essex, which I believe their contracts come up for renewal, and in one of them they were offered less money to continue, and the other they offered about the same amount of money, and the contracts then went, I understand, to Virgin Healthcare. And my acquaintance asked the question for the Freedom of Information Act as to what was the contract amount paid to Virgin Healthcare for these surgeries compared with the previous contract. And she was told that with one of them, they were paid about 60% more, which astounded me and astounded her. And I'd like to hear Mr. Stinson's comments about how we avoid transferring over GP's practices in Mid and South Essex to expensive private companies? Thank you.
So I won't comment particularly on North East Essex, but the question is around, what is our future vision for services? And I can categorically say, I'll have to speak here for CP&R, CCG, because I'm not representing the other CCGs in respect of general practice, specific contracting. But what I am very clear about CP&R CCG is that we've got a group of GPs here that are a good bunch. We've got a good practices, by and large, across our locality, and we want to retain those individuals and those practices and that ethos. So we would always look to the local community to disperse, if we were in the position where a contract came to an end, to disperse that list amongst the local community rather than re-procure from a new provider. Of course, if we are in a position where there isn't a practice that's able to absorb those patients, we would then go through a procurement process. But what we would be looking for is a service that is in line with our vision, which is about a local provision of services linked with local practices to deliver services, linking with the acute service. So I don't know if that's going to answer your question fully enough, but I'm very clear that from your CCG that we will be designing our services based around the needs of our population and our local community of general practices.
Councillor Milne.
It's actually worked. Thank you very much. As a recent patient of A&E at Southend, I have to tell you, I'm sort of bolted together here. I thought, I was very pleased with the hospital, but I thought they were working to the pipsqueak. Everybody was busy, and I mean busy. And what we're really talking about here, and this is where I'm going to come to my question, is logistics, communication, IT. The IT, let's face it, has had real bad press, hasn't it, last month? Because it hadn't been upgraded, it's not joined up. It's also about resources. Now, no matter how you look at it, if anybody goes to A&E with a cold, they're unlikely to be admitted for an operation. So when anyone goes in hospital, I would have thought it's because they need to go into hospital. So you've got resources, you've got numbers of beds. What I don't hear here is what we're going to do about increasing those resources, because we're kind of rearranging the deck chairs in the Titanic. We're moving one thing here, one thing there, moving patients around on busy roads with growing populations. And what it really boils down to is funding and resources and being honest about it. So when you say it's not about money, if it wasn't, then we wouldn't be here tonight. So what I'm saying, I'm worried about the way this is going. It looks as if it fits in as a great deal with the accountants, but what about the personal end of it, which will unravel when the first couple of people have a premature death? So my question is, how are you going to approach trying to get more funding to bring in all the things you need? You need the IT, you need the personnel, you need all of this infrastructure that's outside to stop people coming to hospital unnecessarily. And the modern technologies, and the things like smartwatch on your wrist, you know, it says your heart's slowing down or something, I don't know. But at the end of the day, how are you going to go about that argument? Do you think you're going to get a sensible argument for better resourcing and funding out of all of this to make it work? Because without it, you're going to have a problem, I'm sure.
I'm sure Tom will be able to answer more fully, but there's no doubt about it. More money would be fab. It would be great if someone brought a truckload of money down the A12 tomorrow morning. We'd use it, but we would still change, because it wouldn't solve the GP problem, it wouldn't solve the nursing problem, it wouldn't solve the staffing problem. But please, in your positions of power, more money would be great.
So yeah, just following on from that. So obviously from an NHS perspective, we we get what we're given, if you see what I mean, in terms of the national funding assessment. There is an opportunity though, because actually if we can get a good plan together that we can all get behind, there are various little pots of money out there held by the Department of Health and other agencies that we can access. And so we can use that potentially to support Ian in terms of some of the plans that he needs to take forward, and work that we need to do in terms of improving primary care estate, where there's pots of money again, where if we can hang a good plan together, equally around the IT and some of the other sort of key changes that we know need to happen. So what we want to try and do is, as we develop our plan that we can all get behind, is we can then use that to leverage our discussions with the Department of Health and with our regulators to say, look, we've got some ideas about really good changes we can make which can improve outcomes for our local population, but we're going to need some money in order to make those things happen. That's a much stronger argument than us just going cap in hand and saying we just can't make it work. So if we can get a plan together over the course of the summer, we've got a much better chance of being able to access some of these pots of money that become available from government from time to time.
Councillor Oughton next, please. Sorry.
My question really was mainly about funding. I think most of us agree that the NHS is severely underfunded. Have these changes, these proposed changes, been costed? And how will they be funded? Are we going to hopefully obtain extra funding from the government to cover these quite serious changes that are being proposed?
So kind of my previous answer sort of slightly referred to that in terms of trying to access sort of the additional funding from the Department of Health to fund any changes. What we are doing, because as you've seen, our proposals and thinking is changing, we are costing it as we go along to understand what the financial impact will be on the 3 hospitals and on the NHS more broadly. Clearly, if our plans for community services pay off, which means that there are less people needing to be admitted to hospital, as Ian's already outlined, that's great, because not only is that good for the person who doesn't need to go into hospital, but equally it's a hospital bed that potentially we don't need to use in the future. We are costing it. Obviously, within any final proposal that we come back with, that will be fully costed, and so we can then demonstrate what impact that would have and how any change would be funded over the implementation period of that change. Okay.
And I've got Councillors Webb, Griffin and Cassar to speak to ask their questions next. If there's anybody who hasn't asked a question yet and they want to, can you put your hands up before I go back to people that have already asked a question? So the next one is Councillor Webb.
Thank you. Just got a couple of questions, if I may. My first one is really, who is championing Southend Hospital? It's excellent to see Dr. Howard here this evening, but I know she's not normally present at these meetings, and certainly when I attended last night, there was no clinical representation there. So I would ask, first of all, who is actually standing up for Southend's interests within this process? I'd like to ask a bit more about the STP board, if I may, as well. Could you clarify your roles and governance, please? Who makes the decisions and how? And to what extent is it possible for the decisions of an STP to override those of a consultant body? I'd also like to ask a question about Basildon, if I may. I agree things may in some cases need to be centralised. However, we've just heard that Basildon, if it becomes the Red A&E, will potentially have an extra 220,000 patients going into it. How will Basildon cope when those patients don't just go into A&E, but are dissipated throughout the entire hospital system? As my wife works in a hospital, I know how difficult it can be when a patient goes to A&E. They don't just stay there, they are referred to all other parts of the hospital. So my question there is, how will Basildon cope with these extra numbers? I'd appreciate your answers. Thank you.
Yeah, thank you, Councillor Webb. There were two questions there, and I have been trying to restrict everybody to one question.
Waiting
each,
a long
but,
time, sir.
Yes, I know everybody is waiting, but we're nearly at the end of the list, so I'll let you get away with that one.
Okay. I'll try to get through those. So in terms of who's standing up for Basildon, so who's standing up for Southend? We're all standing up for Southend. I am legally responsible as an executive director of Southend Hospital. I am accountable to you and to the population of Southend and Castle Point and Rochford to make sure that Southend delivers safe, effective services day in, day out. We know that we can't consistently do that all the time now, so we do need to change. I'm sure Ian and other colleagues would say exactly the same thing. In terms of the STP board, the STP board is made up of chief executives from the CCGs and key NHS provider organisations at the moment. They will make recommendations. They do not make any decisions. The decision around any consultation and any service change will be made by the clinical commissioning groups across Mid and South Essex. They have the legal responsibility and the legal duty to do that. So they are the people who will do that. And then in terms of the Basildon, so it would be an increase, I think, from 130,000 to 220,000 would be, I think, is what we described. Clearly, if we were to do that, there would need to be a number of significant changes to Basildon's A&E department. So it would need to be expanded. We'd need to recruit. So within any proposals that we would bring forward, we would articulate these are the changes that would be made to any of the three departments to manage the changes that we would be consulting on from a clinical perspective.
Councillor Griffin.
Thank you all for coming this evening. It's been very informative. Two simple questions. The area that the hospitals cover, how far to the west and the north is your responsibility?
West, I mean, we introduced it with Harlow. Actually, you probably know the actual boundary.
Okay, so west it's broadly over to the M25 boundary and up to Harlow, and then north we sort of kind of cut off around Uttlesford. Is around that sort of part of the world is sort of the furthest north that our patch covers now.
And the health groups that border onto us, are they all making similar changes? Are they going down the same sort of paths or models?
They are making changes, and all STPs, and there are 42 of them in the country, are making changes. Many of them, the proposed changes, are similar to our proposed changes. But actually, you bring up a really important point that it's actually, while we focus on our 1.2 million and that football, the actual borders, and there are patients that will move that way and into us from there. So we have to be talking to them as well, and we are. This is complex stuff.
Right, thank you very much.
Councillor Cassar.
Okay. Thank you, Chair. We have listened to you for a long time and it's been extremely interesting. I still don't understand how the change in the AAEs in the three different hospitals are going to make the system more efficient and, most importantly, more effective.
The changes to the entire system, and I know that might be frustrating to hear that, but it is not just the A&E changes that make the system more effective and more efficient and better for outcome. If we just change the A&Es, it wouldn't work. Actually, you've heard very clearly that probably the majority of change is required in the out-of-hospital portion. And so it truly is an entire system change to create a new way of delivering health in this area. You're right. The A&E changes, any of them, or at any level within those that we have spoken about, whichever level we go to, will not on their own deliver the change. This is an entire system process. Otherwise, it won't work. And that's what makes it so difficult and so complex. And that's why, you know, at times we appear, we're really here to tell you this is where we are.
I don't disagree with you, but there are some caveats to that. So going back to what I said the first time, the A&Es I don't believe are broken. It's about that big Frauti medical group. And I think so much of this does sit in the pre-hospital community situation to get resolution there. I believe without that, everything that we are planning, and that's not just A&E, that's also the specialty pathways, anaesthetics, ITU, vascular, everything. Without solving that, then this will all fail, because as I stated, there is not enough medical beds in the system as it is at this moment in time. It doesn't matter where you put them and how you divide them out. When there isn't enough, there will be spillover into elective care beds, and we will run into the same problem. I would say there are situations where we do have to admit patients that don't have an acute medical need because there is no other safe alternative. So that unfortunately does still happen. It's a little reflection of not all services running 24/7, 365 days a year. So there is improvements that can be had there. And I still am in the situation, you know, at 10 o'clock at night in the A&E that I've got an elderly patient who's got no acute medical problem but nowhere else to go. So there are little gains here and there. But overall, it's that big population group which is causing the problem. And unfortunately, it's that group which is going to grow as well.
Councillor Weston.
Thank you, Chairman. My question is, you all sit around the table, have all these consultations with doctors, clinicals, whoever. What if you can't make a decision that you all agree on? Are you just going to just override it and just go ahead? Thank you.
So we'll have to make a call if we get to that point. I hope we don't. So if we get to that point, then we will have to lay out this is what we think is the best way forward for our system. These are the pros and these are the cons about it. As you know, we're not, you know, that we will go out with that and say that on balance this is what we think the best thing in terms of the reform of health services are, and then we'll have to see the feedback from local communities about those proposals, and that is the purpose of the kind of the formal consultation. And then ultimately it will be a decision which is made by our clinical commissioning groups in terms of is that the way they want to proceed.
So I would add, just to define the clinical leads question, so when I use that term, basically the clinical lead or clinical director is the lead consultant in the A&E. So out of A&E, you'll have 6 to 10 consultants. It's a boss consultant, effectively, that has been you know, interviewed and promoted to that position. So they, in effect, representing their department. I would hope it wouldn't come to that, because you have the 3 boss consultants of the 3 A&E departments that are involved singing from the same hymn sheet.
I think everybody's had an opportunity to speak, so I will return to Councillor Gooding, Ward and Cutmore, who would like to have a second question.
Thank you, Chair. From what I've been hearing this evening, it seems like before we even think about going to the hospital side of things and changing all this system to red, amber and yellow, it would seem that it's far more important to work on the primary care and getting all this in place before we even go anywhere near this, and this should be put back at least a couple of years before this system is in place for what Ian Stidson is proposing.
So it is it's a good point, but I do think this is where the two systems have to work as one system. So we've got to work in tandem on this. And it's about taking the steps together and delivering what we need to deliver out of hospital. The challenge for me always is, from my colleagues, is how fast you can go. And that's the challenge that we've now got to take forward. How fast can we go in terms of out of hospital to enable the system to work effectively? So we've heard from Caroline, Dr. Howard, talking about the frustrations that she has in terms of not having the system around her working effectively, and we've got to find ways of doing that speedily. But it's a complicated system, and we have to get it right.
Councillor Ward.
Thank you very much, Chairman, for allowing me to come back. I think medicine has obviously made enormous strides over the last, 4 or 5 decades. So the fact that we are now actually the victims of our own success, in as much as that we're keeping people alive probably far in excess of the time that they would have been alive for, and we've got a major problem on our hands in regards to that. But one of the things that I noticed from times gone by was convalescence and recovery care, which seems to be non-existent from what I can see and understand. Surely this should be something that could be taken into consideration as you go forward, because one of the things that I think is really necessary within hospital, if people want to move on, is to have really specialised convalescence and recovery and good catering, because that all goes together with healing the patient quicker. And that seems to be very absent in a lot of hospitals, definitely the catering side. And this is something that really does need to be looked at, to have that separated out, where you don't need to have the clinicians there. It's more or less a case of building people up and getting them out and moving them on to somewhere else. So maybe that's something you can look to the future, so that it would actually alleviate this bed blocking problem that we keep on coming back to. Thank you, Chairman.
Well, again, as a clinician, I would agree with you, and I think that's got to be part of the community plan. And I alluded to earlier the problem that we have of discharging people, and then a significant percentage are coming back in a very short time frame as well. And I totally agree that needs to be addressed as well.
Councillor Cutmore.
Thank you, Madam Chairman. Just to say, I know from personal experience a couple of months ago that the actual food at Southend Hospital is very good now. Fortunately, I had a gastrointestinal bleed that you were talking about earlier, so I couldn't sample any of it, but what I saw was very good. But I need to make a declaration, Chairman, because I'm also a member of West Essex Clinical Commissioning Group, and I know that Uttlesford was mentioned, so I represent Essex on that particular panel. So I need to mention that as an interest. But just to say to all of the people that are here, I think we've had a really good discussion tonight. I think we've learnt an awful more. But I think there's still a lot to learn, and I think there's still a long way to go. Now, what I want from you, if I may, is we've convened this meeting here. I'm sure there are other people you're going to have to go to, and there will be consultation out there to actually meet other groups, etc., talk it through. I'm sure I'll see you in my role as chairman of the Local Health and Wellbeing Board for Castle Point and Rochford. But all I'm saying is there a mechanism by which you can keep us up to date so that we know, if you like, the sort of pulse of what's going on and any problems you might have or any opinions you might seek from the public going forward. Now, I don't want to take up a lot of your time on this, but I just wondered if you thought of a mechanism that we could take this forward. So I think it's an important part of the equation for the public, because we represent the public in this matter. Thank you, Chairman.
You're absolutely right. We can't communicate enough, and communication is vital, and we are committed to that, and we do have a communications strategy, a communications lead. We do have a website. We do go out to the public, and we would like to do more and more of it, because uncomfortable though it is at times, it's absolutely vital, because we get information and it informs our thoughts, and we would like to do much more of it, and we will continue to do that. And should you wish us to come back, we would be very happy to do so.
Councillor Black.
On from Councillor Cutmore. Yes, you must communicate. Please come back. I think you go away tonight with views of members here, and I'm making an assumption here, but I think about half of us are doubtful about the orange, red, yellow model, and the other half of us are dead against it. I'm not seeing anybody yet who's, you know. But just to go back to Mr. Abel, you said that we'll go. You are accountable, yeah. Could you clarify in what? I mean, I'm accountable. We are all accountable to our residents. If we get things wrong, they can vote us out. You're in a different category. You're not elected. But in what way are you accountable? And who are you accountable to?
Okay. So, as an executive director of an NHS Trust and NHS Foundation Trust, of which I am accountable to the board, and I am accountable to the governors of the Foundation Trust. The governors of the Foundation Trust are elected by the membership, which are members of the local community. So that is my ultimate accountability through to the governors. I also have an accountability through to the Secretary of State as well.
And the last question, Councillor Hookway.
Thank you, Madam Chairman, for allowing me to come back, and I'd like to thank everyone who's attended this evening. It's been very informative. I would imagine that for most people, in relation to the changes that have been looked at, their biggest concerns are in those very few and occasional situations where it's a life and death situation, and the concern is that they will be treated in the most appropriate, efficient way possible to have the best outcome. Now, another thing that's of interest that's come up this evening is in relation to discussions of how the clinical and the hospital side of things deals with the social care side of looking after the people. Now, it would seem that in some respects this has been talked of as if it was something new, but this has been a discussion that I'm sure that many of you know goes back for decades, and it's been discussed on numerous occasions of how to bring these two together so that there's a seamless change from one to another. Now, for us, you know, the situation with how we deal and meet with you as professionals in your field is very much on a personal basis when situations arise. And mentioned, as made before, about illnesses such as COPD. Well, my father suffered with COPD for many years, and unfortunately last year he ended up in hospital, and it seemed that he, from our perspective, he was released too soon, and the facilities were not there for him to be dealt with when he went back home. And unfortunately, fairly shortly afterwards, he passed away. Now, from my perspective and my family's perspective, we're never going to be completely sure that he was released too soon because there was a need for that bed for someone else, and that will always be with me as to wonder as to why he was released back into the community where he was not properly provided for. Thank you.
I'm really sorry to hear about your father, and my condolences. As a clinician, and I'm sure Caroline would agree, and certainly I know from my experience in one hospital, and I've no doubt it goes for all three, people are not consciously sent home unless it is felt it is appropriate to do so. But, and I think, please take some reassurance from that, and that is a clinical decision. But you do touch on a point that has been made by us all, and that is the ability to convalesce appropriately, the ability to provide social care outside of the hospital is an issue, as well as all the other issues that we have to deal with, and it has to be part of this system improvement that we're making. I was sorry to hear your story.
And the final, oh, sorry.
I was just going to have my condolences too, but also say that that convalescence part is really, as you say, it's not a new problem. This has been happening every winter. I've now been in A&E for 15 years, which makes me feel very old. But this is a problem that's been getting worse and worse over those 15 years, when we do see the big respiratory problems and people coming back not long after they've been discharged from hospital. I think we have to be very careful as well as what we're doing in the community to make sure that actually has an effect. Because having worked 15 years in A&E, I've probably seen 15 years of winter pressure plans which really haven't seemed to make any difference to someone working in A&E as well. There's very limited evidence out there for what happens in the community to prevent people coming in and what kind of care they actually need. So we need to make sure that's done correctly as well.
So the final question, Councillor High, Mr. High.
Thank you, Chairman, for letting me in there. Thank you very much for coming tonight. I think it's been quite enlightening, as other councillors have said. I did hear a presentation at the review committee, I think about a year or so ago, and I can say that things have definitely changed from that presentation to this presentation, so it's good to know that you do listen. The question is, have any of you met with Save Southend A&E to hear their concerns?
So, actually, I met with some of them yesterday because I was at the Westborough Community Association. One of our challenges has been that because we've been in a slightly extended PERDA period, our ability to engage externally and it has been limited. I know one of the things that we talked to them about yesterday was around us starting to develop a dialogue with Save, so we can get a conversation going between the people who are doing some of this work and that group. So I hope that we can kind of build on this conversation that we started yesterday.
Right, well, thank you, everybody. I think we've had a very good discussion tonight. Everybody's had the opportunity to ask questions. Thank you to everybody for coming along and the presentation. I will remind everyone, as members of the public, and that includes councillors, there is going to be consultation starting in December. Yes? And it is moving. So I would urge all the members of the public sitting in the back to ensure that you take part in this consultation, and also the council members as well. But thank you very much for tonight, and thank you.
Will you all please be upstanding while the chairman and the managing director leave the chamber?
You're welcome. Thank you very much. Thanks for the opportunity.